Welcome to the Pancreatic Cancer Action Network's webinar, Treatment Approaches for Pancreatic Cancer. My name is Allison Mayoral, and I am a Patient Central Manager for the organization. January is a time to raise awareness about the importance of clinical trial participation. Pancreatic cancer patients who participate in clinical research have better outcomes. Every treatment available today was approved through a clinical trial. The Pancreatic Cancer Action Network strongly recommends clinical trials at diagnosis and during every treatment decision. For more information, please contact a Patient Central Associate at 877-2-PanCAN or patientcentral@pancan.org. I would like to take this opportunity to thank our webinar sponsor, Ipsen. The webinar is scheduled for 60 minutes and includes a presentation followed by a Q&A session, time permitting. The questions that are relevant to today's topic and more general in nature will be prioritized. A recording of this presentation and the slides will be available under the Educational Events page at pancan.org. Now I would like to introduce our presenter. Dr. Syed Ahmad is a professor of surgery and the chief of the Division of Surgical Oncology at the University of Cincinnati College of Medicine. He also serves as the director of the Pancreatic Disease Center, as well as Associate Director of the UC Cancer Institute and Program Leader in Gastrointestinal Oncology. Dr. Ahmad's research interests include both clinical and translational investigations focused on novel treatment approaches to treating pancreas cancer. Dr. Ahmad is a 2017 Pancreatic Cancer Action Network grant recipient. Dr. Ahmad, I will turn the presentation over to you.
Thank you. Welcome, everyone. And thank you for taking the time to join this webinar. Hopefully you'll find this to be a productive hour. Let me introduce myself. As you heard, my name is Syed Ahmad, and I am Professor of Surgery at the University of Cincinnati Medical Center. I also serve as the Chief of Surgical Oncology and leader of our Pancreatic Disease Center. I'm also a co-PI of the current SWOG 1505 study and the Alliance 021501 study. These studies are evaluating both neoadjuvant therapy for resectable and borderline resectable pancreatic cancers, and I will briefly discuss both of these studies during the talk today. I want to thank the Pancreatic Cancer Action Network for allowing me to give this talk. I understand that the majority of people on this webinar are patients or family or friends of patients. Now, I want to just remind you that some of my slides may seem a little complex. However, I will do my best to explain things as I give the talk. This talk will first give an introduction to pancreas cancer, then review current clinical research trials, and finally give a brief introduction to the future of research. This is a slide that was provided to me by PanCAN. These are the faces of pancreas cancer. Pancreas cancer has been a significant issue worldwide. However, it wasn't until these famous people were diagnosed with pancreas cancer that the public really started to pay attention to this specific cancer. Seen on this slide are Luciano Pavarotti, Patrick Swayze, Stephen Jobs, Michael Landon, and Jack Benny. Unfortunately, there are many more faces that can be placed on the slide. These are the faces that push us to make progress against this dreaded disease. These are the faces of our friends, our next-door neighbors, and our colleagues. And these are the reasons why we do what we do as healthcare providers. Again, the format of this talk will include a background, a brief description of our current standard for treating patients with resectable pancreas cancer, a review of ongoing clinical trials that are attempting to improve our current paradigm, and finally, a brief mention of some specific future studies. Here are some truths regarding pancreatic cancer. Currently, it's probably the 8th most common malignancy, the 4th leading cause of cancer death among men and women. The incidence rates and mortality rates are unfortunately almost identical, and the risk of pancreas cancer increases after the age of 50. We know that for patients who undergo surgery, long-term cure remains a possibility. It's estimated that in the year 2018, 55,000 patients will be diagnosed with pancreas cancer, and unfortunately, in the year 2018, 44,000 patients will succumb to pancreas cancer. The 5-year survival rate has slowly improved and is now around 5 to 10%, and that's for patients, all comers, not just people who are just undergoing surgery. The 5-year survival rate is better for patients who are able to undergo surgery. Most patients, unfortunately, are diagnosed late in their disease after metastasis have formed. And progress in this disease has been slow, but you'll find out during this talk that over the last decade we have made considerable progress, and we have a ways to go. We know that frequency increases with age. The mean onset of pancreas cancer is 65 years. 80% of patients are older than 60. Patients at younger age usually have an undiagnosed genetic risk factor. Higher rates in men are found compared to women, and this is most likely due to differences in smoking. As more women start to smoke, these differences are disappearing. There are also racial differences. For example, rates in African Americans are 50% greater than in whites. Rates in non-whites, non-African Americans are similar to whites. There are regional differences. The highest incidence of pancreas cancer is seen in North America and Europe. The lowest incidence are seen in Africa, Asia, and South America. And again, this may be related to the differences in the frequency of smoking cigarettes. With regards to risk factors, there are modifiable risk factors. Perhaps the biggest one is smoking, as I've commented on several times. Smokers have an increased risk of developing pancreas cancer with an odds ratio of 2.2. This means that there are approximately have a fourfold increase in risk of developing pancreas cancer than those who are non-smokers. Fortunately, you can also see that by quitting smoking, the risk can decrease such that 15 years after you stop smoking, the risk of developing pancreas cancer comes back down to a normal risk factor of the population. Other risk factors for pancreas cancer include diabetes, obesity, heavy alcohol use, and chronic pancreatitis, which is a condition of the pancreas similar to cirrhosis of the liver, where the pancreas becomes fibrotic and scarred. There are also inherited risk factors. There's an entity called familial pancreatic cancer. We do not have a gene specific for this. However, it is defined as having two first-degree relatives or one first-degree relative and multiple second-degree relatives. First-degree relatives would be parents and or siblings. Second-degree relatives would be cousins, aunts, uncles. Other genetic risk factors include both the BRCA1 and 2 gene, which most people associate with breast cancer, and the PALB2 mutation, which interacts with the BRCA gene. Pancreas cancer can be associated with a gene called HNPCC, which is associated with the development of colon cancer. It can be associated with a gene called PRSS that causes pancreatitis, and a gene called STK11 that causes a syndrome known as Peutz-Jeghers syndrome, which can cause intestinal cancer. So there are inherited risk factors that we sometimes will evaluate the patient much closely in a surveillance program. Now, there are many different types of pancreas cancer that can occur, different types of cancers that can occur in the pancreas. However, when we talk about pancreas cancer, we're usually referring to ductal adenocarcinoma, which is characterized by desmoplastic reaction, as can be seen on this slide on the right. You can see that there are tumor cells surrounded by what many people describe as scar tissue, and that's what we call desmoplasia. For the longest time, we used to think that this desmoplastic reaction was just scar tissue. However, recently we now know that this desmoplastic reaction, some people call it stroma, is very important with regards to the pancreas cancer surviving and spreading, and is a focus of intense research in terms of treating pancreas cancer. So how do patients with pancreas cancer present? In medical school, doctors are taught that the classic presentation of pancreas cancer is painless jaundice, and people can certainly present this way. However, in reality, most people present with a combination of symptoms, including weight loss, pain, malnutrition, and jaundice. Other possible symptoms include anorexia, which is losing your appetite and not wanting to eat, pruritus, which is basically intense itching, and in a subset of patients, people can present with new onset diabetes. So when patients are diagnosed with pancreas cancer, the first thought anyone really has is the patient a candidate for surgery? As clinicians, when we evaluate a patient, we tend to categorize them into 1 of 4 categories. This includes resectable, borderline resectable, locally advanced, or metastatic tumors. Resectable tumors are tumors that are confined to the pancreas and are not involving the surrounding blood vessels. These patients can be treated with either surgery followed by adjuvant therapy, which consists of chemotherapy and sometimes radiation therapy. In other institutions, these patients are treated with chemotherapy and or radiation therapy followed by surgery. So resectable tumors can be treated with a surgery-first approach or therapy followed by surgery. Borderline tumors are tumors that have grown outside the pancreas and are touching surrounding blood vessels. And these tumors are usually treated with a neoadjuvant approach. Again, that means we're giving them a combination of either chemotherapy and or radiation prior to doing surgery, and that's done to try to shrink the size of the tumor and make it more resectable. Locally advanced tumors are tumors that are encircling the blood vessels. So it's not only touching it, but encircling it. And these patients get treated with, again, chemotherapy and sometimes radiation therapy. And if the tumor can respond enough, a small subset can get to surgery. And then the last category is metastatic, which means the tumor has spread to a distant site, such as a liver, the lung, or the lining of the abdomen called the peritoneum. And typically, these patients get treated only with chemotherapy. So technically speaking, resectable tumors are tumors that are not involving any of the surrounding blood vessels, and I'll show you some pictures of this a little bit later on, but these blood vessels include the mesenteric artery, the celiac artery, the hepatic artery, and the portal vein. In addition, resectable tumors do not have any blood clot in the portal vein. It has not spread to a distant site, and most importantly, the patient has to be strong enough to tolerate the surgery. This is a CT scan demonstrating what a resectable tumor looks like. For those of you who have not seen a CT scan basically slices you into sections like a loaf of bread, and then we're looking at this from your feet towards your head so that left and right are reversed. In the middle of the tumor, you can see the head of the pancreas, and in the middle of the head of the pancreas, you see a dark area, and that's the tumor. Adjacent to the head of the pancreas are 2 blood vessels. One is the SMV, which stands for superior mesenteric vein, and the other is the SMA, which stands for superior mesenteric artery. And you can see that dark area in the head of the pancreas is confined to the head of the pancreas and is not involving the mesenteric artery or the mesenteric vein. So this is what we call a resectable pancreatic cancer. In contrast, this represents an unresectable lesion that is not only involving the mesenteric vein, but also involves the mesenteric artery. Again, you can see the head of the pancreas, but now that dark area is touching that vein, distorting it, and surrounding the artery. In the middle of the vein, you can actually see a dark spot, and that represents a blood clot within the vein. So this is someone that we would consider not a candidate for surgical intervention. When we evaluate someone for surgery, we look at many factors, including their performance status. In other words, how strong are they? And we usually measure their cardiac performance, their pulmonary performance, and their nutritional status. In addition, we look at blood work to make sure that they don't have any active issues, and determine resectability with a combination of imaging studies, and it depends on institution. These imaging studies can include CT scan, endoscopic ultrasound, ERCP, and or MRI. There are many types of surgery that can be performed. The 2 most common types are the Whipple operation, if the tumor is in the head of the pancreas, and that's demonstrated by the schematic on the right. During a standard Whipple, a small segment of the stomach, about 6 inches of the intestine, the gallbladder, the end of the bile duct, and the head of the pancreas are removed. During a distal pancreatectomy, the left part of the pancreas along with the spleen is removed. So which operation is selected is based on the location of the tumor. If the tumor is in the body or tail of the pancreas, we perform a distal pancreatectomy. If the tumor is in the head of the pancreas, we perform a Whipple operation. Now, when people learn that I'm a pancreatic surgeon, one of the most common questions that people ask is, what's a Whipple operation? Everyone's heard of the Whipple operation. And when I give talks, one of the most popular aspects of the talk is when I go through the schematic of what a Whipple operation is. So, again, this is a little technical, so bear with me, but I'm going to show you step by step how a Whipple is done. I don't expect you to become an expert at it, but it will give you some insight into exactly what we do during the operation. So the first step is to get to the pancreas. The pancreas lies behind the stomach and colon, and the way we get to the pancreas is to separate the stomach from the colon and lift the stomach cephalad towards the head. And when that's done, you can see the pancreas behind the stomach. Once we find the pancreas, the next step is to expose the inferior mesenteric vein as it comes from below the pancreas, and you can see the blue vein coming from underneath the pancreas, the stomach lifted towards the head, and the colon retracted inferiorly towards the feet. The second step is something called the Kocher maneuver. This is when we lift the pancreas off the big blood vessels in the back of the abdomen. These blood vessels are the aorta and the vena cava. So this mobilizes the head of the pancreas off the larger blood vessels in the back of the abdomen. The next step is the portal dissection, where we focus on the area under the liver called the porta hepatis. This is where the blood supply to the liver exists. However, we focus in this area to separate the bile duct from the liver and to divide the blood supply to the pancreas. During this step, we also remove the gallbladder. Next, in a standard Whipple, we divide the stomach and retract it to the patient's right side. We then divide the duodenum and flip it under the mesenteric artery and vein, such that the stomach and the first portion of the intestine have all been separated and are ready to come out. During step 6, we divide the neck of the pancreas and separate the head of the pancreas from the mesenteric vein and artery. Now, the final step of separating the head of the pancreas from the mesenteric vessel is very critical. If this step is not done properly, a positive margin can be left. This step is what separates high-volume pancreatic surgeons from low-volume pancreatic surgeons. And it is this step that's probably the most important in the entire operation. Now, reconstruction is performed by performing 3 connections: the pancreas connected to the intestine, the bile duct connected to the intestine, and the stomach connected to the intestine. After surgery, you can see the schematic on the right shows all 3 connections, and everything in terms of continuity is restored. So the pancreas juice goes in the intestine, it mixes with bile from the liver, and they flow to the stomach where it mixes with food. And even though it looks like we've changed everything you were born with, people can live a normal life. You can eat and digest food completely normally. Now, there's always a period of adjustment, but long-term, people can live close to very normal lifestyle. Now, I always like to show this picture of Dr. Whipple. That's the gentleman in the red box. This is a picture of Dr. Whipple visiting the Department of Surgery at the University of Cincinnati in 1958. He's standing next to the chair of the department at that time, Dr. William Altmaier, who was also a very famous surgeon in his own right. Everyone hears the name, but it's always good to put a face with the name. Unfortunately, after surgery, the cancer can return, and this is why we give adjuvant therapy. Adjuvant therapy, again, means giving a combination of chemotherapy and sometimes radiation therapy after surgery. So where does the cancer return? The cancer can return locally. This is where i.e. where the pancreas used to be, or it can return at a distant site like the liver or peritoneum. These studies that I'm presenting here demonstrate the effectiveness of radiation. When radiation is not given, you can see the recurrence locally, again, locally means where the pancreas used to be, can be as high as 50%. However, when radiation is given, this number drops to single digits, demonstrating that local recurrence can be decreased by using adjuvant radiation. Unfortunately, regardless of whether we use radiation or not, the cancer can return at a distant site, and it is for this reason that we give chemotherapy. So chemotherapy is designed to target distant recurrence, and radiation is designed to target local recurrence. And typically we give a combination of both local and distant therapy, that is chemotherapy and radiation therapy, to prevent recurrences. So does this strategy work? That is, giving radiation chemotherapy, can this improve survival? Well, the answer to this question is yes. However, there is some controversy. The initial study that demonstrated a survival benefit for this algorithm was what we call the GITSIG study, and that's the very first line here, GITSG. GITSIG stands for Gastrointestinal Tumor Study Group. This was a small study that tested the use of chemotherapy and radiation after surgery and found that patients receiving chemotherapy and radiation therapy live longer. Subsequently, several other studies, demonstrated here on the slide, also support the results of the GITSIG study. All of them demonstrate that using chemotherapy and radiation therapy improves survival. However, remember, these were all smaller studies. The standard for treating these tumors remained giving chemotherapy and radiation until the publication of this study called the ESPAC study. ESPAC stands for European Study of Pancreatic Cancer. This is a complicated study, but essentially grouped people into one of four categories: surgery only, surgery followed by chemotherapy, surgery followed by radiation therapy, and surgery followed by both chemotherapy and radiation therapy. This study found that patients getting chemotherapy lived longer. However, radiation did not benefit patients. The results of this study have been accepted by the Europeans, such that the standard in Europe is now surgery followed only by chemotherapy. In North America, most people have not accepted the results of the study based on concerns regarding study design and interpretation of the data. In North America, the question of whether radiation after surgery remains unanswered. Our standard at Cincinnati is to use both chemotherapy and radiation therapy after surgery. So based on the ESPAC study, Europeans only use chemotherapy after surgery. Again, in North America, the role of radiation after surgery remains unanswered. Our standard in Cincinnati uses both chemotherapy and radiation therapy. Now, in 2017, the group that did the ESPAC-1 study published the ESPAC-4 study. This study randomized patients to either single-agent gemcitabine or a combination of gemcitabine and capecitabine, which is an oral 5-FU analog. Per the results of their first study, the ESPAC-1, radiation was not included in either arms. The authors randomized 732 patients to either gemcitabine, of which 366 patients received that, or 364 patients receiving the dual-agent gemcitabine and capecitabine. And what the authors found was the group getting the combination therapy, gemcitabine and capecitabine, had improved survival over those receiving only gemcitabine. So based on the ESPAC-4 study, the results suggest that the standard chemotherapy after surgery should be a combination of gemcitabine and capecitabine. And that's, I would say, is what most people around the country and the world feel is the standard after surgery, a combination of gemcitabine and capecitabine. So the current standard is surgery followed by chemotherapy, and we can discuss what type of chemotherapy, but many, based on the ESPAC-4 study, would say the chemotherapy after surgery should be gemcitabine and capecitabine, and again, depending upon the institution, plus or minus radiation therapy. Now, despite all the research that we have done, we still have a long ways to go. If we look at the results of the major trials in pancreas cancer, we can see we have not made a lot of progress in median survival. This slide compares the progress we made in 30 years from the initial GITSIG study in 1985 that I presented to you to the ESPAC-4 study that I presented to you. And you can see that the median survival over that time has improved, but we have a ways to go. So are we making progress? And the answer is yes, we are making progress. This slide represents two positive clinical trials. In the ACCORD-4 Prodigy 11 study, which is demonstrated by the graphs on the left, this was a study performed in France by Conroy and published in 2011. Patients with advanced pancreas cancer, these are patients with stage 4 cancers, were randomized to receive either gemcitabine or a combination of chemotherapy called FOLFIRINOX. This is a combination of multiple chemotherapies, including folinic acid, 5-FU, irinotecan, and oxaliplatin. In the second study, reported by Van Hoff, 861 patients were randomized to receive either gemcitabine or a combination of gemcitabine plus albumin-bound paclitaxel, also known as Abraxane. Both studies demonstrated that combination therapy were superior to single-agent gemcitabine in improving overall survival in patients with advanced cancer. Again, I want to emphasize that these studies were done in patients with advanced pancreas cancer. So the question remains if these regimens will be equally effective in the adjuvant setting, that is, following surgery. So based on these studies, we're now trying to determine if these regimens can be utilized for patients with potentially resectable pancreatic cancers. Based on these two studies, multiple multi-agent regimens are now being utilized in the adjuvant and neoadjuvant settings. They're also being utilized for locally advanced tumors and are being combined with promising biological agents. So during the next part of the talk, I would like to discuss trials that are ongoing in the four categories that I have listed on the slide. That includes adjuvant studies, neoadjuvant studies for resectable and borderline resectable, and studies for locally advanced pancreatic cancer. Let's first discuss adjuvant therapies. With regards to adjuvant therapies, there are three main studies that we are keeping a close eye on. These studies include the APAC study, the ACCORD-24 study, the RTOG 0848 study. Let's discuss these individually. The APAC study is randomizing approximately 800 patients to either gemcitabine alone or a combination of gemcitabine and albumin-bound paclitaxel or Abraxane. The primary endpoint is disease-free survival, and the secondary endpoint is overall survival and safety. And there are also some exploratory endpoints, including quality of life parameters. The main question in this study is to determine if the combination of gemcitabine and Abraxane is better than gemcitabine alone. This study should finish accruing this year, and we might get some preliminary results later this year. So the take-home message from this study is that this study is trying to determine if gemcitabine plus Abraxane is better than gemcitabine alone following surgery. Again, currently the standard after surgery is based on the ESPAC-4 study, probably a combination of gemcitabine and capecitabine. So we're trying to see if we can do better than that with a combination of gemcitabine and Abraxane. The next study we are paying attention to is the ACCORD-24 study. This study is being conducted in France. This is a multi-institutional randomized phase 3 study comparing 6 cycles of gemcitabine to 12 cycles of modified FOLFIRINOX. The primary endpoint in this study is, again, 3-year disease-free survival, and secondary endpoint is overall survival and disease-specific survival. This study started accruing patients in 2012, and it's estimated the study will complete accruing September of this year. The main question in this study is to determine if FOLFIRINOX is better than gemcitabine alone. So the take-home message from this study is trying to determine if FOLFIRINOX is better than single-agent gemcitabine after surgery. Now, the next study I want to go over is the RTOG 0848 study. This is a complicated study. It's been open for a long time. It was initially designed to answer several questions. However, the main question was to determine once and for all if radiation was necessary after surgery. This study was in response to the controversy started by the ESPAC-1 study, which called into question the use of radiation after surgery. Unfortunately, The study has had a very difficult time accruing patients for various reasons. Based on this, the study has been modified and simplified. This is the new study design. The study now looks like this. The new design allows for 6 cycles of any chemotherapy followed by randomization to observation or radiation. The primary endpoint is 3-year disease-free survival, and the secondary endpoint is overall survival. The study has accrued 500 patients out of a target goal of 930, and it's unclear if the study will be completed. However, it's actively open and is actively accruing patients, and in my opinion is one of the more important studies open right now because it's really designed to ask the question about whether radiation is necessary after surgery. That question remains unanswered. I would like to now shift our focus to neoadjuvant therapy. Neoadjuvant therapy, for those who do not know, is giving chemotherapy and or radiation therapy before surgery. Some institutions use this as a standard regimen in all surgical patients. Some institutions use this regimen for patients that need to be downstage. In other words, the tumor needs to be shrunk prior to surgery. There are 3 studies evaluating this platform, the SWOG 1505 study and the ESPAC 5 study, looking at neoadjuvant and perioperative chemotherapy in the resectable patients and borderline resectable patients. And then there's the Alliance 021501 study, which is looking at preoperative therapy in borderline resectable pancreatic cancer. The first study that I want to discuss is the SWOG 1505 study. This is a study that I'm actually a co-PI on along with Dravindra Sohal from Cleveland Clinic. This study gives patients chemotherapy both before and after surgery. Patients are randomized to either FOLFIRINOX or gemcitabine and Abraxane before surgery and then again after surgery. This study has accrued 104 patients out of a total goal of 150. This study is the first study comparing head-to-head FOLFIRINOX to gemcitabine and Abraxane to determine which is better after surgery. So there's never been a study comparing Abraxane to FOLFIRINOX. This is the first study that compares the 2 regimens that everyone has heard about head-to-head to see which one is actually better. I want to switch the topic of discussion and focus on another group of patients that benefit from neoadjuvant therapy. We know that pancreas cancer can present in various clinical spectrum of resectability. What we have been discussing thus far are tumors that are resectable, that is, not involving any surrounding blood vessels. Tumors that are more advanced locally and circumferentially involve the surrounding blood vessels and are deemed locally advanced unresectable, as seen on the picture on the right. So similar to the picture I demonstrated, you can see the tumor involving both the mesenteric vein and artery. Then there are tumors that are marginally involving the blood vessels and are in turn borderline resectable. So these are tumors that are growing outside the pancreas but barely touching the artery and barely touching the vein. These are what we call borderline resectable tumors. These are tumors where if we do surgery first, the likelihood is that we'll have a positive margin of resection and less better long-term outcomes. And based on this, most people will recommend neoadjuvant therapy for borderline resectable pancreatic cancer. Previously, Matt Katz, who is a surgeon at MD Anderson, myself, Rob Marsh, who's in Chicago, and Joe Herman, formerly at Hopkins but now at MD Anderson, completed the Alliance 021101 study. This study established a current treatment algorithm of giving patients both chemotherapy and radiation therapy prior to surgery for patients with resectable pancreatic cancer. So this study has been completed and demonstrated the safety and feasibility of doing neoadjuvant therapy in patients with borderline resectable pancreatic cancer. This is the results of the study. This was a small study of 22 patients with a median age of 64, and as you can see in the graph to the right, all patients had tumors involving either the surrounding vein or artery. Utilizing a regimen of FOLFIRINOX and radiation led to 93% of patients undergoing a margin-negative resection. Of note, 47% of patients had only 5% or less viable tumor, and 13% had no tumor left on final pathology, demonstrating the effectiveness of this chemotherapy regimen and the use of radiation therapy. Based on the results of that study, we have now opened the following study. This is the Alliance 021501 study. This study randomizes patients into one of two arms. The study is comparing FOLFIRINOX preoperatively to a combination of FOLFIRINOX plus SBRT radiation, which is a form of radiation. So the central question in this study is to determine if radiation is necessary with tumors involving blood vessels. Right now, based on consensus statements, we feel that these patients need both chemotherapy and radiation, but we don't have any level 1 evidence to say that you absolutely need radiation. So the take-home message in this study is to determine if radiation is necessary for patients with tumors involving blood vessels or borderline resectable tumors. In Europe, the ESPAC authors have designed the ESPAC-5 study. This study is not yet open, but again, is currently being designed, and the preliminary proposal is as follows. Patients will get randomized to one of four arms, surgery only, gemcitabine and capecitabine based on the ESPAC-4 study, a combination of FOLFIRINOX or radiation and capecitabine to determine multiple questions, whether chemotherapy is necessary, what chemotherapy is the best, and whether or not radiation is necessary. So this study is being designed but is not currently open in Europe. Let's now talk about locally advanced tumors. Parallel improvements to chemotherapy and radiation therapy have given us the ability to consider a subset of these patients with surgical resections. So for the longest time, patients with locally advanced tumors were not candidates for surgery. But because we've improved radiation techniques, we've gone from conventional cobalt radiation to conformal radiation to what we call IMRT to SBRT, and improved chemotherapy from 5-FU to gemcitabine to combination chemotherapy, we're now seeing that some of these patients can actually become resectable and be candidates for surgery. So with regards to locally advanced pancreatic cancer, these are the studies that are currently investigating novel treatments for these patients. You can see the CONCO-7 is looking at the role of chemotherapy plus radiation. The SCALLOP-2 study is looking at radiation plus or minus a biologic called nalfinavir. And more recently, the LAPACT study was presented at ESMO in Europe in 2017, and an update was given last week in San Francisco. What this study demonstrated was that a combination of gemcitabine and Abraxane led to 33.6% of patients having a partial response with a median percent tumor change of 18%, demonstrating that not only could you decrease the tumor, but that the disease remained stable for a prolonged period of time and improved survival. So we know that multi-agent chemotherapies in this cohort of patients can potentially make them resectable and let them live longer. So we definitely have made progress. However, if we're going to make further progress, we need to understand pancreas cancer biology, and the future treatments are going to be developed understanding how pancreas cancer grows, understanding how pancreas cancer spreads, and understanding how pancreas cancer survives. With this in mind, the next series of slides will focus on some active areas of research. Some of these slides, again, are a bit complex, but I will try to explain them as best as I can. Of course, I'm more than willing to pause and explain further if necessary. Before I go into new drugs being developed, and since this is Pancreas Cancer Clinical Trial Month, I wanted to spend a few minutes discussing the different phases of clinical trials and how how drugs progress in development. Clinical trials can be categorized in one of five categories, ranging from phase 0 to phase 4. Phase 0 trials are those that are testing newly discovered drugs in humans for the first time. The question really being asked is, does this drug hit the target it is designed to hit? Phase 1 trials determine optimal dose of a new drug, determine the toxicity profile of the drug, and the mean tolerated dose of the drug. Phase 2 studies focus on drug activity and safety. Phase 3 trials evaluate clinical outcomes compared to a control arm, which typically is the standard of care. And finally, phase 4 trials evaluate long-term outcomes of drugs that have been accepted to clinical practice. Getting new drugs into clinical use takes time and requires a systematic approach. For example, the drug first needs to go through preclinical testing, i.e. testing in animals. Once we know that the drug works in animals, we usually apply for something called an IND, Investigational New Drug Application. This outlines what the sponsor of the new drug proposes for human testing and clinical trials. The study then goes into phase 1 studies, subsequently into phase 2 and 3 studies, and then once we demonstrate the effectiveness of therapy, we submit a NDA application, a new drug application, to the FDA, which then considers the drug. The FDA then reviews the drug application and then either approves or does not approve the study, and then eventually drugs go into phase 4 study. So it does take time and a systematic approach to make sure the drug is effective and not harmful. In order to make progress in pancreas cancer, new treatment really is combining efforts on many fronts. New strategies in pancreas cancer include targets linked to pancreas cancer, which we've been focused on the last several decades. But now we're also looking at targets less specific to pancreas cancer and more recently looking at immune therapies, which I'll also talk about. One of the new areas of research that we're looking into, as I mentioned earlier in the talk, was we're looking outside the pancreas cancer, looking at the stroma. We used to think that this was just scar tissue surrounding the pancreas cancer and was not important. However, we have learned that the stroma is very important with regards to promoting and sustaining cancer progression and drug resistance. In addition, there are a lot of other cell types in the stroma that talk and interact with the cancer cells. One of these cell types are immune cells. These immune cells come in many varieties. Some of them help the cancer cells and some attack the cancer cells. In pancreas cancer, there's a preponderance of immune cells that actually and unfortunately promote and help the cancer cell. Based on this, there is active investigation on targeting many different targets within the stroma. Listed on this slide are some of these targets. The one that has gotten the most attention is the second one, which is hyaluronidase. Hyaluronidase is a drug that targets hyaluron, which is a substance that's made by fibroblasts, which is in the scar tissue of the pancreas cancer. And fibroblasts makes this hyaluron that serves as a lattice or framework that cancer cells can attach to and use to grow and spread. So pancreas cancer uses these scar tissue to attach to, and it helps them get from one area to another area and helps them basically grow and spread. So the excitement for targeting hyaluron was based on the small study shown on the top graph, where patients randomized to either gemcitabine and Abraxane alone or gemcitabine and Abraxane plus a drug that targets hyaluron, PEG-PH20. And this demonstrated that patients getting the PEG-PH20 had improved progression-free survival. Based on this, 2 larger studies were opened. The first was the SWOG 1313 study, which randomized patients to FOLFIRINOX plus or minus PEG-PH20. The second used gemcitabine and Abraxane with or without the PEG-PH20. Unfortunately, at last week's ASCO 2018 meeting in San Francisco, the authors presented the results of the SWOG 1313 study and demonstrated that there was no benefit to adding the PEG-PH20 to Gem-Abraxane. The authors, however, are trying to determine if certain subsets may potentially benefit. So one of the things that people are looking at now is whether tumors express hyaluron, and if they do express hyaluron, whether those patients will benefit from this drug. The second study, which is being conducted globally, combining gemcitabine and Abraxane with PEG-PH20, remains open and is currently accruing, and we await the results of that study. Approximately 10% of patients with pancreas cancer have a BRCA mutation. You may know BRCA is a gene associated with breast cancer. Tumors use the BRCA gene to repair DNA damage. When patients have a mutation in BRCA, they use another pathway called PARP pathway. Based on this, we now know that if someone has a BRCA mutation, they use the PARP pathway to repair damaged cells. So in order to combat this, what we are now doing are using PARP inhibitors in patients that have a BRCA mutation. Based on this, multiple studies are currently open evaluating PARP inhibitors in advanced pancreatic cancer, and these studies are listed here and are currently accruing patients. This is a busy slide, but what it shows is that cancer cells metabolize sugars differently than non-cancerous cells. New drugs are being designed to take advantage of this phenomenon called the Warburg effect. I won't go into it too much, but just, the point of this slide is that cancer cells metabolize sugars differently. So based on this, we have designed drugs that can block the processing of glucose by pancreas cancer. One drug is CPI 613, which blocks the processing of glucose at several sites. This drug was evaluated in a single-arm study of patients with, again, advanced pancreatic cancer and demonstrated significant response when this drug was combined with traditional cytotoxic chemotherapy. Again, you can see the pink bars demonstrating that a significant number of patients had a decrease in the tumor size when given this drug that blocks the pancreas cancer's ability to metabolize sugar. Based on that small study, this current study was designed and will be opened. This study randomizes patients to FOLFIRINOX alone, which is the current standard, versus FOLFIRINOX versus the CPI 613 study. Another area of active investigation is understanding pancreas cancer stem cells. We know that in cases where patients get treated with chemotherapy, sometimes we find that cancer cells completely respond and go away. But if we really look at these patients, we find a population of cells that remain. And when we study these cells, we know that these cells are actually what we call cancer stem cells, and they have stem cell properties. Based on this, we know that we believe that these cancer stem cells repopulate the cancers, and that's why the cancer comes back. And so based on the studies such as this have demonstrated the benefit of combining stem cell inhibitors with traditional chemotherapy. In other words, we have to not only target the cancer cell, but we have to also target the stem cells. If we give chemotherapy, the cancer cell may go away, but the stem cell remains, and if given enough time, the stem cells will recreate the cancer. So in order to prevent that, we have to also target the stem cell. In this study of 66 patients with metastatic cancer, the addition of a stem cell inhibitor combined with gemcitabine and Abraxane was associated with overall survival of 11 months and significant downstaging of measurable tumors. And again, based on that, a larger study to compare the addition of the stem cell inhibitor to gemcitabine and Abraxane has now opened and is accruing patients in patients with metastatic pancreatic cancer. This study will evaluate overall survival as the endpoint and will accrue at least 1,100 patients to the study. Well, what about immune therapy? We know that the stroma that we've already talked about also contains significant population of immune cells. As we said, these immune cells come in many varieties. Some of them help the cancer cells, and some attack the cancer cells. In pancreas cancer, there is a preponderance of immune cells that actually and unfortunately promote and help the cancer cells. Pancreas cancer has a paucity of T cells and is largely composed of bone marrow-derived myeloid and macrophages. These cells actually turn off the immune cells that come into the tumor to attack the cancer cells. So we know that substances called chemokines help recruit the bad immune cells into the tumor. The bad immune cells are TAMs, or tumor-associated macrophages, and the bad immune cells are also myeloid-derived suppressor cells. So we can block this recruitment of the bad immune cells into the cancer by targeting these chemokines. CCL2 and CCR2 chemokines are one of the chemokines that we're targeting. We know that in a preliminary study of 47 patients with advanced pancreas cancer, utilizing this chemokine inhibitor led to a shrinkage of the tumors and increased the population of good immune cells in the pancreas cancer. So by blocking this chemokine, we inhibited the recruitment of the bad immune cells, which led to a preponderance of the good immune cells, which are there to attack the cancer cells. At the University of Cincinnati, we're investigating a substance called alternatively spliced tissue factor. Tissue factor is a protein involved in the blood clotting cascade. Our team here at Cincinnati has found a variant of this compound that's produced by pancreas cancer, and we have demonstrated that this variant helps promote pancreas cancer growth and helps the pancreas cancer spread. We have developed antibodies against this substance, ASPF, that we can demonstrate in animal models that actually kills the pancreas cancer. We have now, in the process of humanizing this antibody, and eventually, hopefully within the next year or so, we'll be going to a phase 1 study to study this antibody targeting alternatively spliced tissue factor in human patients with advanced pancreatic cancer. So in summary, improvements in survival have occurred in the last 30 years. Newer multi-agent combination chemotherapies have improved survival in the metastatic setting. The role in the adjuvant and neoadjuvant settings are being determined currently with the trials that went over. The role in locally advanced tumor has to be determined. We know the role of radiation in patients with resectable tumors has to be clarified. And we know that newer biologic agents continue to be investigated in the metastatic settings. And these agents may make their way into the algorithm for resectable tumors, but they're not yet ready for prime time. I would say the future is bright. We know that awareness for this disease is at an all-time high. This includes awareness in clinicians, researchers, funding agencies, patients, and caregivers. Based on this, more research is being done on pancreas cancer than ever before. Visible progress is definitely being made, and newer drugs are on the horizon. Because of this awareness, new scientists that would not otherwise consider doing research in pancreas cancer are focusing their attention and their efforts in pancreas cancer. And it's because of this awareness and this focused attention that we're actually making progress. I want to leave with this quote from Randy Pausch, and if you don't know Randy Pausch, I would urge you to go to YouTube and Google his last lecture. He was a professor of computer science at Carnegie Mellon, and he was diagnosed with pancreas cancer, and he went to his class and gave what he called the last lecture, and it's extraordinarily inspiring lecture. And if you haven't heard it, I would tell you to go listen to it and listen to his words. In that lecture, he uses this quote: "The brick walls are there for a reason. The brick walls are not there to keep us out. The brick walls are there to give us a chance to show how badly we want something. Because the brick walls are there to stop the people who don't want it badly enough, they're there to stop the other people." And this quote, to me, really summarizes our battle in pancreas cancer. Every brick wall can be broken, and we're hammering the brick wall. That brick wall is going to fall, and we're going to make progress, and we're seeing it more than ever before. Thank you very much for your attention.
We have some time for questions. The first question is, can a local recurrence be surgically removed?
The answer to that is yes, but in selected patients. So if it is only a local recurrence, we make sure that we do a very thorough workup to make sure that it's not anywhere else. And typically, the way we would approach it at Cincinnati is to first treat them with a regimen of chemotherapy to make sure that the local recurrence does not pop up anywhere else. And over a period of several months, if the local recurrence remains only in that one area, then we would consider a certain subset of patients for surgery. But again, we have to do careful selection to determine who is and is not a candidate for surgery.
Thank you. The next question is, do you recommend that all resectable patients undergo neoadjuvant therapy?
This is one of the biggest questions in the field today. There is no consensus on this. There are people who believe neoadjuvant therapy should be given to everybody, and there's some people who don't feel neoadjuvant therapy has a role in resectable patients. There's never been a clinical trial demonstrating that neoadjuvant therapy is better than adjuvant therapy. However, having said that, the benefits of neoadjuvant therapy is really theoretical. What do I mean by that? So if you ask yourself, what's the most important aspect of the trimodality therapy, that is surgery, chemotherapy, and radiation therapy, the most important aspect in terms of improving long-term survival is probably chemotherapy. If you look at patients who get surgery first, about 15 to 20% of patients unfortunately never recover from the surgery to go on to get chemotherapy. So one of the theoretical benefits of neoadjuvant therapy is give people chemotherapy, which some would believe is the most important aspect of treatment, when they're the healthiest before surgery so they can actually get it, and then do surgery so that it makes people get the chemotherapy. The second theoretical benefit of neoadjuvant therapy is that it lets us test the biology of the tumor. And what I mean by that is that sometimes when patients present with what we think is a resectable tumor, and we do a CT scan, we do a PET scan, and we say that we don't see evidence of any spread anywhere. But sometimes some patients have some spread that haven't yet reared its ugly head, and if you give them another couple months, the metastasis that was already there before they met the doctor eventually becomes radiographically apparent. So by giving neoadjuvant therapy, you allow patients who have metastasis that haven't reared its ugly head to form, and so you prevent that patient from undergoing unnecessary surgery. If you look at series where patients get surgery first, about 15 to 20% of patients will unfortunately develop recurrence very shortly after surgery, and those are patients that, if they had undergone neoadjuvant therapy, would have progressed and not undergone unnecessary surgery. So the benefit of neoadjuvant therapy is allowing them to get chemotherapy and selecting patients who are most likely to benefit from surgery.
Thank you. The next question is, I noted vitamin D on one of the stroma slides. Would a high dose of vitamin D help or hinder pancreatic tumor growth?
Right, so that's an active area investigation. There are actually some clinical trials that are open that are looking at the benefit of vitamin D in patients with pancreatic cancer and combining them with cytotoxic agents, chemotherapy. And so, the data on vitamin D is really more from epidemiologic studies. If we actually take patients with diagnosis of pancreas cancer and look at their vitamin D levels, you'll see a significant number of patients have very low vitamin D levels. And so, again, whether or not giving them vitamin D helps to prevent the cancer, improve survival, those are things that are actively being investigated.
Thank you. The next question is, can you explain the differences between R0 and R1 resection results?
Very good question. So as cancer surgeons, we always try to perform R0 resections. There are three types of resections, R0, R1, R2. R2 resections are cancers or surgeries that we never want to perform. That's when you cut through the cancer. You know you have a positive margin. And when you do an R2 resection, the surgery does not help the patient. R1 resection means that the margin was microscopically positive. In other words, the surgeon does the operation. He thinks he's all the way around the tumor and that he has a negative margin, and only on final pathologic review by the pathology doctors, he says when he looks under the microscope, he sees some microscopic cells within millimeters of the resection margin. That's an R1 resection. In R0 resection, is all the margins are greater than 2 millimeters and are negative. We know that patients who have R0 resections have the best long-term outcomes. When we do a Whipple operation, we try to get an R0 resection, and again, the area that's most often positive is that tissue connecting the pancreas to the artery, the SMA. And again, skeletonizing the SMA is a very important aspect of the surgery and really distinguishes surgeons who do this operation a lot from those who do not. And so R1 is a microscopically positive margin. R0 is microscopically negative margin. R2 is macroscopically positive margin.
Thank you. And we have time for one more question. How long does it take for a phase 3 clinical trial to make it through the trial and get FDA approval?
So how long does it take for a phase 3 to be conducted? I would say that typically it depends on the sample size. Again, phase 3s are usually 2-arm randomized studies, including hundreds of patients. On average, takes at least several years to complete and get mature data. How long does it take to get a drug phase 3? That could take years.
Thank you. We would like to thank Dr. Ahmad for his presentation. The PowerPoint slides and a recording of this webinar will be available at pancan.org under the Educational Events page. There may be a delay of several days before the information is posted. Your patience is appreciated. Once again, we would like to thank our webinar sponsor, Ipsen. A survey will pop up once you leave the session today. Please take a moment to share your feedback. If you have questions or would like a personalized clinical trial search, please contact Patient Central at 877-2-PanCAN and ask to speak with an associate. This concludes our webinar. Thank you.